Hello everyone, welcome back to Channel Essentials of Acute, Emergency, and Critical Care. In today's video, we'll discuss diabetes insipidus, an important cause of polyuria and hypernatremia, especially in ICU and endocrine practice. We'll cover what diabetes insipidus is, types and pathophysiology, clinical features, diagnostic approach, how to differentiate central from nephrogenic DI, acute and chronic management. Let's begin. Diabetes insipidus, or DI, is characterized by the inability of the kidneys to conserve free water, leading to the excretion of large volumes of dilute urine. Remember the classic triad: polyuria, polydipsia, and dilute urine despite hyperosmolar plasma. Unlike diabetes mellitus, glucose metabolism is normal. Daily urine output is typically more than 3 liters per day in adults, often 5 to 15 liters per day. In severe cases, it may exceed 20 liters per day. The resulting water loss can produce hypernatremia, hyperosmolality, dehydration, neurological symptoms if thirst cannot compensate. There are 4 major forms. Number 1. Central diabetes insipidus. This occurs because of reduced ADH production or secretion from the hypothalamus or posterior pituitary. Common causes include neurosurgery, head trauma, pituitary tumors, craniopharyngioma, stroke, hypoxic brain injury, autoimmune disease, and idiopathic cases. Number 2. Nephrogenic diabetes insipidus. Here, ADH levels are normal or elevated, but the kidneys fail to respond. Common causes include chronic lithium therapy, hypercalcemia, hypokalemia, chronic kidney disease, obstructive uropathy, and genetic mutations affecting the V2 receptor or aquaporin 2 channels. Number 3. Gestational diabetes insipidus. Occurs during pregnancy due to increased degradation of vasopressin by placental vasopressinase. Number 4. Primary polydipsia. This is not true DI. Excessive water intake suppresses ADH secretion and causes polyuria. Differentiating this condition from DI is clinically very important. Patients usually present with polyuria, nocturia, excessive thirst, preference for cold water, fatigue, and dehydration. If access to water is impaired, patients rapidly develop hypernatremia, confusion, irritability, seizures, and coma. ICU patients are particularly vulnerable because many are sedated, intubated, or neurologically impaired and cannot drink water. The diagnosis starts with confirming hypotonic polyuria. Step 1. Confirm polyuria. Greater than 3 liters per day or more than 50 milliliters per kg per day. Step 2. Measure urine osmolality. In DI, urine is inappropriately dilute, usually less than 300 milliosmol per kg, often even below 200 milliosmol per kg. Step 3. Measure serum sodium and plasma osmolality. Typically, plasma osmolality above 295 milliosmol per kg, serum sodium often above 145 millimoles per liter, especially when water intake is inadequate. Water deprivation test. This remains the classic diagnostic test. Normally, Water deprivation increases plasma osmolality, stimulating ADH release. Urine becomes concentrated. In diabetes insipidus, urine remains dilute despite dehydration. Then desmopressin is administered. Interpretation. Central DI. Urine osmolality increases significantly, usually more than 50%, indicating the kidneys respond when ADH is replaced. Nephrogenic DI. There is little or no increase in urine osmolality because the kidneys remain resistant to ADH. Today, many centers also measure copeptin, a stable surrogate marker of vasopressin. High copeptin suggests nephrogenic DI, while low levels favor central DI. Treatment depends on the underlying type. Central diabetes insipidus. The treatment of choice is desmopressin, available as intranasal spray, oral tablets, intravenous, and subcutaneous preparations. Monitor carefully to avoid water intoxication and hyponatremia. Patients should drink according to thirst rather than excessive scheduled water intake. Nephrogenic diabetes insipidus. Management focuses on correcting the underlying cause. Examples include discontinue lithium if possible, correct hypercalcemia, correct hypokalemia. Interestingly, thiazide diuretics reduce urine volume by causing mild extracellular volume contraction, which enhances proximal tubular sodium and water reabsorption. A low-sodium diet further reduces urine output. NSAIDs such as indomethacin may also decrease urine volume by reducing renal prostaglandin synthesis, although long-term use is limited by adverse effects. For lithium-induced nephrogenic DI, amiloride is particularly useful because it blocks lithium entry into collecting duct cells. Let's finish with 5 important take-home messages. Number 1. Polyuria with hypernatremia should always raise suspicion for diabetes insipidus. Number 2. Low urine osmolality despite hyperosmolar plasma is the hallmark of DI. Number 3. Desmopressin response differentiates central from nephrogenic diabetes insipidus. Number 4. Never correct hypernatremia too rapidly. Gradual free water replacement is essential to avoid cerebral edema. Number 5. Always identify and treat the underlying cause because many cases, especially postoperative or drug-induced DI, may be reversible. Thank you for watching. If you found this video helpful, please like, subscribe, and share it with your colleagues. In our next video, we'll discuss more evidence-based critical care content. See you in the next video. Stay safe and keep learning.